Are you looking for help for your food addiction and you don't know where to start? Welcome to the series, The Food Addiction Frontlines, where we uncover the expertise and services available for food addiction. I'm Dr. Vera Tarman, an addictions physician specializing in sugar and ultra-processed food addiction. In each 15-minute episode, we'll meet leading experts making a difference in this field. They will share their journey, their training, the unique services they offer for all who suffer from food addiction, so that you can find the treatment that is best for you. Today, we speak with Dr. Marty Lerner. Welcome, Marty.
Thank you, Vera. Glad to be here.
It's about time we got you on this series. What inspired you to specialize in food addiction?
I try to give a very short version of all of this, but to suffice it to say, I had a personal investment in looking for a career, narrowing in on how to treat, at the time, obesity. And the reason for that is twofold. One is wearing two hats. On the personal front, I suffered from what used to be called juvenile onset obesity, which later I came to understand and do understand was a symptom of an eating disorder, specifically sometimes referred to as binge eating disorder, but I also refer to it as food addiction. And on the professional front, I chose a career in medical research, specifically the regulation of appetite from a neuropsychological perspective. And so began my career, which morphed in moving from the laboratory with very friendly rodents, which we used to dissect, to human subjects. And from there, decades later, we sit for this interview.
Can you share more about your specific training and qualifications for this field of food addiction?
Sure. A way I tend to look at it is my mother put me on a school bus when I was 5, and I didn't get off till I was 33. With that, I pursued a career in neuropsychology and went the route of getting my PhD in clinical psychology, but was mainly studying and working in the area of research. And again, was very fascinated personally and professionally with investigating all the complexities of the regulation of appetite, mainly for myself, but also for the world at large. That took me from the laboratory or in vitro work to in vivo or real world work, and then to treating people with food addiction, as well as morphing into eating disorders and widening the net of people that I was working with.
What kind of services do you provide either personally or at Milestones for Recovery?
I have to tell this story by prefacing it that my personal experiences spilled over to my professional, in that I was invited to participate in what was called a physician's recovery network called PRN. And the reason for that is I also suffer from chemical dependency or substance use disorder. In my late 20s and early 30s, I crossed the line into what I would refer as an addictive relationship with substances and began a journey in personal recovery using a 12-step model and an abstinence model with alcohol and prescription medications. And so that led me to take that experience in treatment, which included an extended period of time in a residential program that was not hospital-based, but consisted of professionals who were also in recovery and learning to live in a real-world environment with the support and structure of what at the time was referred to as a three-quarter-way house. When I returned, I replicated that model to treat people with food addiction and eating disorders. And the model still exists today at Milestones, which is extended care or residential treatment for people that suffer with food addictions, as well as people that suffer with related eating disorders.
Just to recap, it's a residential
Sure.
center for how long?
The minimum stay we suggest is 30 days. The average stay usually is between 45 and 60 days, where people live in apartments There are on-site people to provide support and supervision, but they go grocery shopping, prepare their own meals, attend local support groups such as OA, Smart Recovery. Many are also duly diagnosed with not only depression, but substance use disorders. So they attend AA meetings, NA meetings, and in general, support groups intended for people that have an addictive or compulsive relationship with either dieting or overeating.
So it's a residential setting, like one big house?
The typical model used to be years ago a hospital based program that was 24/7 medical supervision on either a psychiatric unit within the hospital or a specialty unit within the hospital grounds. It became a true residential model in that it was not hospital based but freestanding, but had all the accoutrements of a hospital, including a multidisciplinary staff, a pharmacy, a physician, nurse, dietitian, afforded the structure and support of a hospital environment without the restriction of a hospital environment, would allow people to start to live in recovery. We were teaching people how to fish rather than serving them a fish. The concept is having a group of apartments or townhouses, which we have, that are interconnected by proximity but independent. And in one of those apartments, we have resident managers that are there 24/7 and nursing staff within a larger complex or community that's open to the public. So we're trying to make a facsimile of a real world environment that also can afford the structure and supervision that's needed for people who are, the way I put it, trying to stand up on their skis with recovery, but without the same restrictions.
So that's quite unique. Like you said, replicating the community. What's unique about your service?
There are two pieces to look at: the setting or the environment, which we just described, and the other is the overall approach. What makes us a little unique is that we treat food addiction through an abstinence model. In other words, we look at substances such as sugar, flour, and then we tend to individualize things like grains and other substances, artificial sweeteners and ultra processed or processed food, and so on and so forth. But nonetheless, we are an abstinence based program for people with food addiction. They work with a dietitian, they work on a food plan as opposed to a diet per se. And we also treat people that are duly described as food addicts in the typical sense that we define it, but also have behavioral components that would meet criteria for bulimia or purging types of anorexia, and certainly binge eating disorder. And then last but not least, we have a few people that we treat, although we screen them, that may not fit the food addiction model, but seem to need, at least temporarily, a very structured and supportive program, but do benefit from what I would refer to as simply healthy eating, which is nothing more than an abstinent food plan. The overlap between what we're calling an abstinent food plan and simply healthy eating is nearly 100%. We treat eating disorders as well as food addiction within this model, which is unique.
Another unique feature of your program is that you are covered by insurance. So how do you make that happen?
We tend to have experience in dealing with insurance companies. And as I alluded to, there are languages that you need to speak when you're dealing with eating disorders and food addiction. There's the language of recovery. There's the language of professional speak. And then, of course, there's a language of managed care. So having experience with that, we've been able to contract with various insurance companies, and we refer to these disorders as eating disorders.
Good. Co-occurring issues like mental health, how do you deal with?
Yeah, when we do residential treatment, we recognize at this level of care, a significant, if not a majority of patients that we see meet the criteria for major depression, bipolar disorder. Many that we see also have co-occurring substance use disorders. So our staff is multidisciplinary and has experience with all those different entities.
How do you work with the family? You mentioned 12-step as an alternative support system.
Yes. When you talk about families, we have to delineate between spouses and biological families with patients that may be living at home or don't have a significant other in their life other than their parents. Usually, but there are exceptions to this, we have found that we need to perform what I like to refer to as a parentectomy, because the enmeshment between the parents and the adolescent 18 and over that we treat, or even young adult, is toxic and counter to recovery. We get them to detach, go to an Al-Anon type program, and make the patient responsible for their own recovery. With spouses, it's more dynamic in terms of having to involve them, but also direct them in terms of how to be supportive rather than intrusive with ongoing treatment and recovery.
And 12-step, do you work with that?
We do, and for a majority of patients, they've had mixed reviews in going to programs like OA that tend to be more diet oriented and instead of recovery oriented. And by recovery oriented, going beyond the food and the weight issue into the other components, emotional, physical, and spiritual healing. And a lot of our patients, because they're coming from substance use histories, lend themselves to either open or closed AA and NA meetings, which tend to be more comprehensive in working beyond the first step or substances. We also offer the option for patients to go to Smart Recovery, which is a non-religious, non-spiritual program that's for all addictions and can appeal to people that benefit more from a strictly cognitive behavioral approach.
What are some challenges that you encounter in your work treating with food addiction?
Oh, there's so many. Where to begin? I think the challenges are integrating a recovery program that's abstinent model or 12-step model, and at the same time recognizing the individual nuances with a person. So, for instance, we need to be somewhat flexible with a food plan. Where there is very little negotiation is with ultra-processed food substances, sugar, white flour, and so on. But some people can tolerate stevia, for instance. Other people can tolerate caffeine. Some people can tolerate certain grains. So you have to individualize it, but at the same time recognize that as a disease entity, there are common denominators. So individualizing treatment, I think, is the greatest challenge.
Given that challenge and other challenges, how do you personally stay out of the way of the recovery of your clients? What do you do to take care of yourself?
Yeah, that's an excellent question. As a professional, I struggle, but work as a team so that I'm not projecting my own recovery and making the assumption that what is good for me is good for everybody else. And the second piece in working with a team, as I said, the challenge of it is recognizing what my own specific recovery program needs to consist of. My recovery from alcohol and other substances is decades in the making. So I have my own little posse, I call it, or tribe or circle. And what I do for a living is divorced from what I do as a person in recovery. And that's been very important for me. And on the food addiction, eating disorder side of the court, it's very much the same.
How can people learn more about your services?
Yeah, it's very simple. If they go to Milestones program, it's all one word, .org, of course, they can see and read more about what we do. I also have written a book, much like Vera, but more specific to what the Milestones program is about and why it's about that. You can get that by going to the website for free, or you can order it on Amazon. And I get 6 cents a copy for royalties, so I'm not going to retire on it.
Anything that I missed that I didn't ask that you'd like to showcase about your program?
It's been a program that's been in existence for more than 25 years, and that the folks that are working there have evolved into a very resourceful and professional team. And it's a program I would send my daughters to if they needed to go.
Last words of hope to leave with the listener.
Last words to hope, leave with the listener. Yeah, I heard something that I really loved, and it's about having trouble with sleep, but it also would apply to all of this as well. Rather than count sheep if you can't sleep, why not speak to the shepherd?
That's great. Thank you, Marty, so much for
I
participating
enjoyed
in
it.
this interview.
Thank you, and thank you for listening.
Sugar is the enemy, corrupting the minds of the teens, expelling you not to proceed. Your body's your temple, your mind is your key to a life tapped into happiness. Have it, don't dream it. If only you could see it. It's all in you and I. It's all in you and I. It's all in you and I.